As we record this, which is Thursday, September 19th, Nancy Pelosi has finally released her promised plan on how to control drug prices. And I haven't had a chance to read it in enormous detail. I looked at an early draft of it last week, but it has changed somewhat. I keep looking at this thing and saying, this is not bad. So my next guest will help us talk through that in much more detail. He's been on the program before. Stephen Knievel is an advocate for Public Citizen for its Access to Medicines program. He focuses on expanding affordable access to medicines. He's an expert in policy matters in this area. And I did not know till I was just looking at his resume now that he also has a degree in philosophy. So, Steve, first of all, welcome to the program. And secondly, maybe you can help us with the post-Hegelian universe of drug pricing. So, welcome.
All right, thank you.
So tell us about Nancy Pelosi's drug plan.
So we're finally seeing the landmark H.R. 3 legislation that we've been awaiting for now, 9+ months in this Congress. Lowering healthcare costs, including lowering prescription drug prices, was, one of the main planks of the House Democrats for the People agenda as they're running in the elections last year. And it's the last piece of sort of those signature proposals that to be introduced that we've been waiting for. Significantly, it would finally allow the government to negotiate drug prices with pharmaceutical companies. There are other measures included that would require drug companies to provide a rebate when they increase prices beyond inflation for Medicare. And there's other pieces that change the sort of cost sharing amount and put in place an out-of-pocket cap for seniors on Medicare. But the negotiation piece is probably really the top line aspect of the proposal. There have been a number of leaks and articles that have come out about what the proposal would ultimately include, what the structure of the negotiations would look like, how many drugs they'd be negotiating, et cetera. One aspect that had been reported as being included that was removed was including some sort of binding arbitration system wherein there would be a third-party arbiter that ultimately decides the price of a drug. That's not included. That's something that groups like Public Citizen, champions in Congress of progressive policy, have been pushing back against. And it's a big win and a testament to the work of patients and advocates to have that removed. There's still some important areas where the proposal is in need of improvement, and I'm happy to talk about those. But you're right that this is certainly some positive movement in the right direction, and it's it's someplace to build from.
So let's talk first about several of those provisions as well. I'm glad to see there was a win on the binding arbitration. It allows negotiation, as I understand it, government negotiation that is, not for all drugs, but for 250 specific named drugs. Is that correct?
Yeah, it's actually even a bit worse than that. So there's a drug selection process in the bill where they outline a universe of 250 drugs where there could potentially be negotiations. And for drugs that are not included in those 250, then there's zero chance that they're negotiated. But there's only a requirement that 25 drugs are negotiated. So I think there's some worry. We certainly have some worry about whether that 25 floor could ultimately be all that they do. But we're going to have to take a close look at the text. But that's something that's really important. 25 in the scope of drugs is not that many. another piece that we're concerned about is the ability of the proposal to lower high launch prices for prescription drugs. So, year after year in the U.S. and in the other countries that are referenced in this proposal as sort of a benchmark to limit the level of the negotiated price. Companies raise the prices of new drugs beyond the level of the drugs that they launched last year and the year before that. So long as we're not really addressing those high launch prices, then that's a major shortcoming that needs to be addressed as well.
So in terms on the shortcoming side, limited list of drugs, nothing prospective about new drugs that come on the market. I can well picture Big Pharma gaming the system by when it's forced to negotiate a lower price for a drug, accelerating, pushing up the date of a replacement drug, that kind of thing, maneuver that they do. I guess on the upside, losing the arbitration provision, the fact that their negotiations would, as I understand it, would cover all purchasers of drugs, right? So if you take drug X, if you take insulin or another drug and say, this is the price we've agreed upon, that price would be applicable not only to Medicare or other government purchases, but also to any private payer that purchases the drug as well. Am I right about that?
Yeah, so there's mostly. So there's a provision that would require the drugs, the price that's negotiated by the government to be made available in the commercial sector, whether it be employer plans or individual Obamacare market plans. However, there isn't a requirement that the plans actually accept those prices. And, you'd think it would be in their interest to do so, but we already currently see games where, oftentimes when plans are negotiating with drug companies, they don't negotiate just the price on one drug. They negotiate the price of all the drugs at the same time that are offered by that company. So they might, make some trade-offs in such negotiations. And that would, if they did so, then, theoretically you could see some patients paying higher prices than are negotiated in the private sector.
And then you have the added complication of, I don't know what the numbers are now, but you have pharmacy benefit managers, right, that act as intermediaries a lot of times
Right.
for drug purchasing for private plans. And even if they add that further complication of bulk negotiation with manufacturers and that type of thing, right?
Mm-hmm. That's correct. That's exactly the kind of worry I'm talking about. It might be in the intermediaries' interest to gain like a higher rebate overall rather than accepting the price that's negotiated by the government.
Is there any, and again, we're talking with Stephen Knievel, who is with Public Citizens Access to Medicines program. Steve, is there any way, based on the 250 number or anything, any other information we have, is there any way to guess of the universe of drugs out there now, not in terms of total sales, for example, is there any way to guess or estimate how much of that universe is affected by this? I mean, I know drugs are not, the drug market is not like the car market, where if you hit 5 manufacturers and 25 brands of vehicles, you've got 80% of the market. It's a lot more distributed and dispersed than that. Do we have any idea how much of the drug market we're talking about might be negotiated under this plan?
Yeah, so if you do get 250 drugs, but again, that's only the universe that would be eligible for negotiations, not those that would actually be necessarily negotiated. That gets us to a substantial chunk of the market, 70, 80%. But the bill prioritizes which drugs are being considered by the highest total spending for the U.S. healthcare market. So that makes sense at first blush, but then you have to think about sort of new drugs that come on the market that are have super high prices that are only for a relatively small number of people. So maybe the total amount of spending isn't that big. In that case, you could see patients in the private sector who don't benefit from that out-of-pocket cost cap that's being introduced for Medicare, who don't have the price of their drug negotiated. And, these drugs are being launched in the hundreds of thousands of dollars, if not above $1 million for a course of treatment. So by artificially putting in place a limitation on which drugs are negotiated, you're really maybe leaving some patients at risk from high prices still. And just to pull back for a second too, there is zero policy reason to put a limitation like that in the bill. There is no good rationale for arbitrarily limiting how many drugs are negotiated. Negotiation should be available for all drugs, and the government should try and do it for as many drugs as they can. Especially with a bill like this, which is sort of it's hard to imagine the president signing this right now, or Mitch McConnell bringing it to a vote in the Senate. So there's no reason to compromise down from the best possible policy. And with the sort of artificial limitations on the number of drugs that are negotiated, it very much looks like that's what they've done. So that's worth highlighting and thinking about as well. Even if, ostensibly 250, it's many drugs, but it's still missing a lot.
Yeah, and it raises the question of, are Democrats already negotiating against themselves, even in something that's supposed to be messaging and aspirational, something that's supposed to tell the American people what they would do if they had the Senate and the White House. So fair point. Now, people who follow policy in this area know that there are, for example, under current law, there's something called march-in rights, where government can manufacture or permit a drug to be manufactured by someone other than the patent holder if it's not available to those who need it. I mean, I'm oversimplifying a little bit. There have been other proposals to say there should be a public option for drugs if the holder of the patent, many of these patents developed at government expense anyway, if the holder of the patent won't make it available to those who need it at a reasonable price, the government can have it manufactured by someone else. What does this proposal, this bill, do if, for example, among the 250, I know it limits to the small universe, so already that's a limitation. What does it do if there's a negotiation and the government and the patent holder can't agree?
I'm glad you brought that up. So that's sort of the third major sort of area where we could see some improvement optimally. So currently under the bill, if a drug company refuses to enter the negotiation process, or if it pulls out of the negotiation process before a price agreement is reached, then they're faced with a penalty of 65% tax on their sales, and that insofar as they continue not to comply and engage in the negotiations, that increases 10% per quarter up to a maximum of 95%. What it does not do is anything about touching the underlying monopoly that allows companies to charge the high prices in the first place. Public Citizen, many progressive groups have been championing Representative Lloyd Doggett's Medicare Negotiation Competitive Licensing Act, where the remedy is if the company doesn't sell the product at a fair price, then the government licenses generics to enter the market. And with generic competition, you get down to basically close to the marginal cost of production, which is very small for most drugs. So failing to address that underlying sort of monopoly problem sort of limits the ambition of the proposal. And moreover, I mean, just being real here, whatever meaningful proposal on drug pricing is passed, the pharmaceutical industry is going to litigate. I'm not sure exactly what they're going to litigate on, but they're a litigious industry. So having a robust set of sort of enforcement mechanisms is going to help with that too, and that's another good reason to include something like licensing in the proposal.
So, in conclusion, I guess I would say yeah, my personal view of big pharma is that it should be broken up, and any pharma executive who knowingly permitted the opioid epidemic should have their homes taken away and turned into rehab centers. So no bill out of this or any Congress is going to satisfy a guy like me. But having said all that, where would you, in your work, which is much more grounded and sober analysis perhaps than mine, how would you grade? I guess in conclusion, how would you grade this bill from Nancy Pelosi and her team?
It's a good start, and like I said at the top, this is really positive movement from where we were initially, and it's good to see some advancements of legislation in this area, but we also want to see it built upon and improved upon before it really does everything that we want it to do.
All right, I think that's a great summary, and I thank you for that. Stephen Knievel, advocate for Public Citizens Access to Medicines program. And as always, Steve, thanks for coming on the program.
Thanks for having me. It's been a pleasure.